Hello. So we will start now the second lecture about the ASD. It will be about imaging of ASD. So by clinical diagnosis, by history or by symptoms, we had a patient with ASD. So what do we expect that imaging modality will add to this diagnosis? Actually, we could summarize them in 3 points. First of all, we have to confirm that there is an ASD. And how many ASDs do we have? How many? 4 types. So it should be one of the 4 types. So we have either to see the VSD, to direct visualize the VSD, it's direct visualization, or to find an evidence that there is an ASD. And we will see later how to find that. Second thing, that we have 4 types of ASD, and with each type there is a preference to have an associated lesion. So that everything is possible, but common is common. So with type with the ASD premium, you find an associated lesion. With the sinus venosus defect, you find another associated lesion, but everything is common, but could happen, but common is common. And the third point, we have to estimate the pulmonary artery pressure. So in each ASD case, we have to provide these 3 points. Do we have an ASD? Which type? Is it hemodynamic significant or not? Do we have an associated lesion with this type or not? And the third point is the pulmonary artery pressure, and this is very easy and should be applicable to have. Is it clear, the strategy? Okay. Okay. Some points to be remembered, that the echo is very sensitive, and detection of ASD is actually up to 90%. It's very high sensitivity. We can improve it to 100% if we use the agitated saline. Agitated saline means that you inject via the arm and saline with bubbles, so you will find the bubbles crossing the septum. So it's very sensitive. That's why you will find that the echo is more than enough for almost all the cases of ASD. As Hatem mentioned, we didn't refer the patient for cath, and very rare to have it for MRI or CT, unless we have a specific questions. But transthoracic echo, usually more than enough. The size of defect on 2D does not correlate with the size of the defect. I mean, the ASD is 3D structure, so when you find it small in one plane by echo, does not mean it's small. So you have to check in orthogonal planes, and you have to check for the hemodynamic effect, like dilatation of the ventricle and the atrium. Usually it's said that if the defect is more than 15 millimeter, the shunt will be significant. So actually this is as a rule of thumb. The flow left to right shunt will decrease if the pulmonary artery increased, and we will find how to measure it by echo. Is that clear? So the first thing that we will detect the ASD by visualization. From the echo, we use the 2D and the color Doppler. The indirect measurement, we measure the hemodynamic significance of the dilatation of the ventricle. So this is apical 4. So we have here the atriums, and we have here the ventricles. Do we see any defect in that? It is an ASD lesson, so we will focus on that part. So we have here the left atrium, we have the right atrium, and we have here the interatrial septum, and we have defect. How do you describe this defect? 7 ASD blood. So this is the defect that we have seen in the previous movie. It's closer to the EV valve, and by color we find that the direction of the color is from left to right, is closer to the probe, so it's red. So this is how we detect that we have a defect. Is it clear? Okay. ASD premium should be differentiated. It's very easy to detect. It's very easy, as we see in that image. It's defect in the intraatrial septum. It's more closer to the EV valve than to the roof of the atrium. However, it should be differentiated from other 2 common findings. Okay, this is an apical 4, but it's coming from another perspective. So we find here something, right? Again, this is the EV valve. This is a defect above the EV valve. Is that ASD prima? Say it. No, it is not. Then it should be another thing. It is in the same place. So actually the intra-atrial septum primum was here. We saw it in the first part of the movie. But what happened here? This is the intra-atrial septum primum. But what happened that we go posteriorly and we open another structure in the same place? It is the coronary sinus, normal structure. So it's not an ASD primum. So you have to differentiate between the dilated coronary sinus, that opening here. It is normal structure, it's not an ASD. Is it clear? Okay. It might be advanced, but I put it here. This is apical 4 also, and we find something that passing here. What happened here? It could be again. We find here like a defect. Is that clear? We find here like a defect in this structure. This is the defect. It could be an ASD primum, but what is the trick here? That to detect an ASD primum like that, you have to have the tricuspid and mitral or 2 EV valves open. So you detect that this is the defect. Actually, what we saw it in that direction is one of the common pitfalls for juxtaposed of the right atrial appendage to the left side. So actually, if you didn't see the mitral and the tricuspid open and there is defect, you have to be suspicious in the diagnosis. You get what I mean? Actually, this is more advanced in the technique, but the message from here to the ASD primum is very easy to diagnose. If you find the tricuspid and mitral are open and you find it more posterior angulation or more anterior angulation, it will be tricky. Is it clear? Okay. We have another type of the VSD, of ASD. So actually this is subcostal view, and this was color and this without color. So we have here, this is the liver, so this is the right atrium, the more close to the right atrium, and this is the left atrium, and this is intra-atrial septum. And what we saw here is the fact. And here with the color, it's shunting from left to right because the flow is red. So this is ASD. And this is the defect, and the rest of the septum, we call it REMS. So when this defect is central and we have enough REMS, this is high possibility to send the patient for the percutaneous flush. So actually, we can see here, this is a defect, very easy to detect. And by color, we find also that color crossing the septum by color Doppler. It's very easy in children to find it in the beast, but in the adults, it might be difficult in some views to see it. Okay, this is the third type of the ASD. This is subcostal view. So if I here, this is sweeping as a loop. This is the ventricles. And we go now to the septums. The flow is coming the red from above. This is the both atriums. The closer to the liver is the right, and the other one is the left. Flow is red in superior vena cava because it's coming from above towards the brow. And we have here septum. And when we look again for that loop, we will find that superior vena cava is overriding the septum. So superior vena cava is going to the right atrium, but at the same time, there is a defect in the septum. So this is superior vena cava, and this is the so this is superior vena cava, and this is the septum. Actually, septum should be here, closing that, but now we have a defect. So superior vena cava is overriding the interatrial septum. This kind of defect, what we call it? Sinus venosus defect. And the most common type is to be superior, as we say here, sinus venosus defect. Okay. And by color, we find the superior vena cava is red, because here is the probe, so the flow is coming from superior vena cava towards the probe, so it's red. And here, the defect that we saw, that we have here, missing part from the intra-atrial septum, and the missing part is close to the superior vena cava. So it's a sinus venosus defect. Is that clear? Okay, this is one of the rarest form of ASD, coronary sinus defect. So actually, here, the left ventricle, this is the right ventricle, this is the aorta, and the mitral, and the left atria. And here we find a flow passing from the coronary sinus that behind the left atria, and should have no communication between it and the left atria. But we find the blood is going from the coronary sinus to the left atrium, and the blood coded in red direction, because in red color, because it's going from the coronary sinus towards the probe, so it's color coded by red color. So actually, echo showed us that the 4 types of the ASD, primum, secundum, sinus venosus, and the coronary sinus could be detected in different degree of difficulty between the peds and the adults, but we can detect it by echo. So actually, we can see the ASD by 2D and by color, and by echo also we can detect if this ASD is hemodynamic significant or not. If the ASD, which is shunting left to right, is hemodynamic significant, so which chamber from the heart will be dilated? Right atria and right ventricle. This is good. So actually, it's volume overload, and as Hatem said, it's volume overload on the right side. So if we imagine that we have an extra amount of blood that will pass across the ASD, so actually the amount of the blood going to the right atrium will be more, and which is going to the right ventricle will be more, and the pulmonary artery will receive more blood compared to the aorta, and it goes back from the lung to the left atria. So the extra amount will pass through the ASD, and the normal amount will pass through the ventricle. So how can we see that? Echo is the best method to detect that, but echo is not a quantitative method. So we will say by echo that right ventricle is dilated, and semi-quantitative method, and we will detect on the how the septum is moving during diastole and during systole. So, for example, this is the example. By global eye evaluation, we will say that this is the left ventricle and this is the right ventricle. So we'll say it's dilated. Some of us say it's mildly dilated, moderately dilated. Actually, it's roughly. So by echo, it's quantitative. And we will look for the movement of the septum. Normally, the septum usually is going towards the right ventricle. It's convex in shape, but in volume overload in the right ventricle. Only in the diastole, the amount of the blood could push the septum towards the left ventricle, so it will be, instead of convex shape, it will be straight line. So actually, if we have straight line here, and like a semicircle here, so it gives the D shape of the left ventricle. So both of these sides, globally evaluation of the right ventricle, and looking for the movement of the septum during systole and diastole. So if the volume in the right ventricle is bigger enough or higher enough than the left ventricle, it will push the septum towards the left ventricle and giving it a straight line. So the left ventricle will be D-shaped left ventricle. So as we say, Echo is not a quantitative method, but this is the most practical way to see the ASD and to semi-evaluate the rhythm. Sometimes we need to have measurements. Actually, in the borderline shunts, as Hatem said, ASD is not an indication for closure, but the hemodynamic effect is the trigger behind to close it. Sometimes the ASD is in grayish area. It might be significant, it might be not. So sometimes we need more evidence that the right ventricle is dilated and there is more blood going to the lung. So cardiac MRI, in that way, this is CINI, echo-like imaging. We have it for the ventricles, from the base, from the mitral and tricuspid. We cut the ventricle in 2 slices until we get the apex. By this way, we can quantify the volumes of the ventricle. It's computer games. We draw the contours around the ventricle in the left side and in the right side, and we will have in each slice the amount of the blood that's going in each slice in each phase. And we have the in-systolic volume and in-diastolic volume, so we can calculate the ejection fraction and the stroke volumes in both ventricles together. So this is the way that we calculate the ventricles, and we got something like that, and we got numbers. What we got by MRI is something like that. That they do the analysis and they do the post-processing, and you give you a lot of numbers. It's very easy to understand that if you know what's behind it. So actually, this is a report of the MRI in patient that had an ASD. So they said the left ventricular end-diastolic volume is 120, and left ventricular end-systolic volume is 40. So left ventricle ejected how much? How much? 80. The stroke volume of the left ventricle is 80. Then they said the right ventricular end-diastolic volume is 240, and the right ventricular end-systolic volume is 100. So the stroke volume that coming from the right ventricle is how much? So stroke volume from the RB is 140, and from the LB, which one had more? The RB is more stroke volume. Okay, keep it that in mind. Then the aorta is ejecting 80. Do you remember the stroke volume of the LB? Yeah. It was 80. So all what goes out the left ventricle goes to the aorta. This is correct. And pulmonary valve is 120. So we have here 140 getting out the right ventricle, 120 went to the lung. Look for the aorta and for the pulmonary, which one had more blood? The pulmonary. So the lung receive an extra amount of the blood receiving going to the lung. If we draw it in the that way, so we have here aorta receiving 80 and pulmonary receiving 120. It shouldn't be like that. What goes to the aorta should be equal to what goes to the pulmonary, unless we have a shunt. So actually we have here a shunt, so this is more blood going here, and we have a volume overloaded right ventricle. So actually this is a typical case of an ASD. We don't have to do an MRI for each case, but sometimes we have to demonstrate in the borderline shunts that there is an hemodynamic significant shunt. Is that clear what we receive by MRI and how we calculate or interpret that? So now we finished the first part.
What about the 20?
What do you think? What do you think? So we have something happened in systole. So 140 ejected from the right ventricle, 120 went to the pulmonary, and 20 went somewhere else, like okay. Now we go for the second. So the first one was to confirm or to disagree with the diagnosis that there is an ASD, and if there is an ASD, we have to describe which type of that and we have to describe is it hemodynamic significant or not, or do we need help from other imaging modality like cardiac MRI. The second question is, do we have an associated anomaly? And this should be positive or negative. So if you don't have an associated anomaly, you have to say it's normal, normal, normal about the following points. And if you have an associated anomaly, you have to describe it. With the premium ASD, it's usually apart from the canal, the atrioventricular septal defect. We will go through it. But the most common thing to have a cleft mitral valve or left-sided EV valve. How we can find it? This is short axis, and this is the mitral, and this is the septum, and here you will lift it, and you will find the defect towards the septum. This is the echo. You see it here. This is the mitral, and the anterior leaflet is clefted. It's teared. So we have a tear here towards the septum. We have to address this associated anomaly because this left AV valve should be repaired on the sympathetic. Is it clear here, the movie? So we have here, this is the mitral, and here the cleft. You see it? So this is the most associated anomaly with the ASD camera. With the Secundum ASD, we have association with pulmonary valve stenosis and with the mitral valve prolapse. With the sinus venosus defect, what is the most common associated lesion? لا مع sinus venosus defect anomalous pulmonary venous drainage. Usually the right upper pulmonary vein in the sinus venosus defect is going to the superior vena cava, either close to the atrium or far away from it. Pulmonary veins is very easy to detect in children, but in adults, make it low profile to send it for other imaging modality, either CCT or MRI, because it's very easy to mess up. Actually, we don't have only 4 pulmonary veins. It might be 5. It might be an accessory pulmonary veins. So keep it low profile to use another modality to help you to detect if there is a partial pulmonary venous drainage and where is the drainage site. So with the sinus venosus defect, we have anomalous pulmonary venous drainage. With the coronary sinus defect, what we have to check? Left SVC. So actually, with the coronary sinus defect, we have to confirm: do we have a left SVC or we don't have an SVC? Is it clear for the associated lesion? So you have to confirm the type. We have to confirm in the premium we have clefts in the mitral valve or not. In the secundum, what about the pulmonary valve and what about the mitral valve? In the sinus venosus defect, what about the pulmonary veins? In the coronary sinus, do we have or don't have the left SVC? Okay, we will come to the last point to estimate the pulmonary artery pressure. Actually, if you are a surgeon, if you are a cardiologist, you have to ask about the TR. And we will understand why we measure the TR in that. We had it in the previous lecture that we said there is something called Bernoulli equation, right? Do you remember what Bernoulli equation is?
Pressure gradient can be measured by estimated equation in your form square.
Exactly. So Bernoulli equation means that you can measure the pressure gradient between 2 chambers in the heart if you know the velocity of the blood that is going through the valve in that. So the Bernoulli equation, as Ahmed said, it's 4 multiplied by the square of the velocity of the blood. So actually, you will start that we would like to know the pulmonary artery pressure exactly, and the easiest way is the invasive. You go to the lung by a cath or Swan-Ganz, so you measure it invasively to know what the pulmonary artery pressure. But this is not applicable in the patients, so we will go for non-invasive. So if you don't have a pulmonary stenosis, so in systole, the pulmonary valve will be open, and the RV pressure should be equal to the pulmonary artery pressure. Agree on that point? If you don't have a pulmonary stenosis. In systole, not in diastole, but the pulmonary artery opens. So the RV pressure in systole will be equal to the pulmonary artery. In other way, if we know what is the RV pressure in systole is, it will be indirectly an equivalent or surrogate for the pulmonary artery pressure in systole. Okay, this point number 1. So the tricuspid valve here, if he has a tricuspid incompetence, is it systole event or diastole event? Systolic. So if you have the flow during tricuspid is in diastole, so the blood goes from the right atrium to the right ventricle. When the tricuspid valve close in systole, shouldn't be any regurgitation. If there is any, if a small amount, so it is systolic event. Back to the Bernoulli equation. If we know the velocity that the blood ejected back to the right atrium, and we squared it, multiply by 4, so we know the pressure gradient between the RV and the right atrium, correct? Keep in mind that the right atrium pressure will be the lowest is 5 and the highest is 15. So if you have a normal right atrium, it is around 4 or 5. And if it's the biggest right atrium that you ever see, it will be around 15. So now we have known the pressure in one atrium, in one chamber, I mean the right atrium. So we can easily detect the other right ventricle. Is it clear? We will make it by numbers. So this is tricuspid regurg, systolic event. So we have it here. The tricuspid regurg is 4 meter per second, and the machine do it for us. So it did it the Bernoulli equation and said that the pressure gradient is around 65. If we have the right atrium here, it's not small and it's not that big. So I'll give it 10, for example. Do you understand? The pressure here is 10. And the pressure gradient between the right atrium and the right ventricle is 65. So the right ventricle systolic pressure is دخلنا طب عشان ما نعملش الحكايه دي. So it is 10 and the pressure gradient is 65. هنا هيبقى كام؟ 75. So the pressure in the RV is 75. If we don't have pulmonary stenosis, so 75 in systole in the RV should be equivalent to the pressure in the pulmonary artery. Get it?
Associated all the time?
Oh, there is always a tricuspid regurg. Look for it. يعني actually, if you didn't have a tricuspid regurg, you should say tricuspid regurg is constant and you don't have any amount. It's not about the amount. It's about if you have any travel, just a small jet, it will give the idea of the Bernoulli equation that the pressure gradient in the RV during systole is X, and this is equivalent to the pulmonary, provided that we don't have a pulmonary stenosis. Why? If you have a pulmonary stenosis, then the situation is not the same. That RV is not the surrogate of the pulmonary artery pressure in systole because we have a pulmonary stenosis. You got it? So actually, we look for it, and in our GCC and in discussion with the surgeon, you will hear, do you have a tricuspid regurg? How often do you ever listen to this question? I think many times, because we look actively for the tricuspid regurg, because this is the way that we can estimate the pulmonary artery pressure non-invasively. There is other ways like pulmonary incompetence, but we will not go through it. In any ASD case, you have to look for the tricuspid regurg. You have to look. You can find your way between the modified views, but you have to find the tricuspid regurg. If you find the tricuspid regurg and there is no pulmonary stenosis, so the square, the velocity of the tricuspid regurg multiplied by 4 is in the machine. And keep in mind that the right atrial pressure is between 5 and 15. So you make your equation. Is that clear? Okay. Normally, that we expect some increase in the pulmonary artery pressure with the long-standing left to right shunt across the ASD. If we find that the pulmonary artery pressure is high, we have to refer for other options. We will talk about that in, I think in the BSD in more details. But actually, we have to send this patient if we have suspicions about increasing the pulmonary artery pressure by the non-invasive way. We have to send it for the cath. Never deem a patient an Eisenmenger before doing a cath. So if the non-invasive method showed the pulmonary artery pressure is not high, well and good, but if showed it high than acceptable level, so we have to send it to the cath lab to decide what to do first. Okay. So we finished the 3 points. Actually, we finished all what we need to know. We have to confirm the diagnosis. We have to confirm if it's hemodynamic significant or not. You have to give a positive answer or negative answer about the associated lesion, and you have to mention something about the estimated pulmonary artery pressure, estimated systolic pulmonary artery pressure. As Hatem said, in the ASD secundum, usually think about the percutaneous option. So I think that Abdurrahman gave a good lecture about that, but this is how we think about closing the ASD by cath. This is the device that delivers to the heart via the right side, so the femoral vein, inferior vein cava, then they go to the septum in that way, and they close it by double disc devices. Actually, by echo, you have to keep it in mind that the only defect that can be closed by this way is the ASD secundum. The size of the defect should be less than 40 because for technical reasons. I mean, the biggest device couldn't cover a defect more than 40. So if you have a ASD secundum but it's 42, sometimes we have to send it for the surgery because we don't have enough size to close this VSD. REMS, it means that the defects around the remnant part from the septum around the defect, it should be more than 5 millimeter, not in all directions. I mean, who is interested in that can join the cath team. So in some REMS it's more important than the others, and they don't have any additional lesions to be sent for that. Keep in mind, the ASD secundum, you have to search for the enough data to send the patient for the cath lab. Follow up after closing by device or surgery. Actually, we follow the patients for 6 months to avoid the infective endocarditis. The patients with ASD, if they have been treated either surgically or by cath, we follow them in the clinical and very long term. I mean, every 5 years. We didn't expect any problems with such simple surgery. With the adults with ASD, the unoperated patients is very likely to have an AF or atrial flutter. Usually they are candidates in the EPS studies. Older patient with ASD, there is no significant effect on the survival. I mean, if we have a patient with 40 or 50 years old with an ASD, closing the ASD will not benefit them on survival level. However, it's improve the quality of life, improve the functional capacity of them. So keep in mind to balance the risk of the operation. It will not add to their survival, but it will improve the quality of life. So actually, if the quality of life can be improved by diuretics, it's more safer for everybody. You got my point? So this is our dilemma with the adults with ASD. ECG. ECG is very beneficial in ASD. I mean, we will go that in the canals, but with the ECG, the QRS axis in all ASD should be right, because the right side is dilated and it's more volume overload in the right side. Except in the ASD primum, we will not go to the details now, but the ASD primum is the only ASD that shows left axis deviation. So actually, if you have a patient with ASD primum or a suspected ASD, and you find this ECG with left axis deviation, usually you find lead 1 is positive and lead AVF is negative. No more details more than this. But we have Chicken guns, yes. No, it's not chicken guns, it's the other way around. So lead 1 is positive and lead APF is negative. Actually, in the old days, especially in down babies, they do an ECG because it's easier than echo. If you find that left axis deviation is very high, suspicion that this baby have a canal, either complete or partial canal. So look carefully for the ECG in ASD. All the other ASD, the sinus defect, sinus venous defect, the secundum, the coronary sinus defect will have right axis deviation. The only ASD that will have the left axis deviation is the ASD prem. We'll know the details in the canal. So in the imaging of ASD, echo is the first imaging modality, and as we have seen that all the ASD types could be detected by echo. Multi-slice CT might have a rule only in the sinus venosus defect to detect which type of anomaly? What? Partial anomaly in the pulmonary base. Cardiac MRI, we keep the cardiac MRI about the question about the hemodynamic significance of ASD. So to confirm that the ASD is significant, we measure the volumes of the ventricles and we can measure the QPQS. Cath, when we will need a cath? And when we have by non-invasive estimated pulmonary artery pressure, the pulmonary artery pressure sounds to be higher than acceptable levels, so we do the cath invasively to measure the pulmonary artery pressure. Transesophageal echo, we keep it in the ASD secundum to measure the REMS or the remnant from the ASD if the ASD will be closed by device. I'm done with that. Any question about that? Clear? Shall I ask about some questions? حد عنده أسئلة؟ Who would like to start? Ahmed.
A 24-year-old female whose significant past medical history presents to her primary care physician as exercise intolerance. She has been trying to exercise to lose weight but becomes short of breath. After only manual effort, her temperature 37, blood pressure 110/70, heart rate 110, respiration 20, oxygen saturation 94, Romeih physical examination show normal jugular venous pressure, normal breath sounds, grade 2 out of 6, systolic pneumonia at the left upper sternal border, fixed splitting of S2, laboratory studies normal, ECG normal sinuses and right longitudinal torque and left axis deviation. Which of the following is a likely diagnosis? ASD ring.
Okay. Who disagree or who agree? Who agree? Okay. only حاجة disagree. Who disagree؟ باين ما عندهمش رأي يعني ولا ايه؟ Okay. ASD premium واللي أحمد said that diagnosis.
يعني هي it comes with ASD.
Yeah. ECG because he said it's left axis deviation. Okay, how do you explain the murmur is correct? It's a correct answer. It is a correct answer. How do you explain the murmur?
It's an overflow over the pulmonary valve, causing like functional pulmonary stenosis.
This is correct. Actually, when you said fixed splitting of the second sound, this is pathognomonic for ASD. Fixed splitting for ASD sound that P component became away and fixed then the aortic component, so ASD. And they said the systolic murmur over the left parasternal, over the left upper sternal border. This is the pulmonary side. As Hatem said, it's ASD is silent, but we have an overflow about so we make our mind that this is an ASD. Actually, when they said right bundle with right axis deviation, it would be secundum or coronary sinus defect or whatever. But when it said right bundle branch block with left axis deviation, so he described an ASD problem. This is the correct answer. This is the correct. The answer is an ASD problem. The second one, I don't know your name. Yeah.
Gita.
Okay. Yeah. Shall you start to read it?
Okay, let me try. Should I read?
Yeah.
Oh, which of the following statements regarding acute septicemic conduct type is correct?
Yeah. Okay.
A. Acute septicemic conduct type is common cardiac malformation.
Okay.
B. Acute septicemic conduct type is rare cardiac malformation.
Yeah.
C. Acute septicemic conduct type is commonest is common with disease.
Yeah.
D. Acute septicemic conduct type is usually form of heart disease.
Okay, so we will go for the first one. ASD secundum is the common cardiac malformation. True or false? It's true. The ASD is the one of the commonest congenital heart disease, and the secundum is the commonest type. So this is common. This is true. ASD secundum is a rare cardiac malformation. It's wrong. ASD secundum is a component of Weber's disease. I don't know what is Weber's disease, so there's not. Is ASD is cyanotic heart disease. Baby comes with baby are fluid. No, they are not. They are not. So it is not. This is the correct answer. Okay. The third colleague, Austin Primum ASD are associated with tricuspid stenosis, pulmonary stenosis, left axis deviation, right axis deviation. Left axis deviation. And what more? And what more? Epicanal. And what more? We have just said that. Cleft. Mitral cleft. Right? And the cleft and the cleft and the mitral. Okay. Daphne. Yes, true. Because if you have a hemodynamic significant, if you have a significant shot, we don't have to have a figure. We don't have to have it's 2 or 3 or 4, but QPQS, yes, the left to right shunt determine the closure. This is true. And any volunteer? Okay, go. Shatra, lay false. Yeah, we have just said that there is some defects, although it's a secundum, but it's too big for the devices. Have to have special devices can be ordered, but sometimes there is no way to have it. Sometimes the REMs are not enough to support the devices, so this is the correct answer. Yes, secundum could be closed by percutaneous, but not all cases. Okay, I'm done. Any questions? Yeah?